Let's have a discussion about the local complication of anesthesia. Coming to the topic, this is an outline which shows what are all the local complications will occur when you administrate the local anesthesia, which includes needle breakage, ocular complications, paresthesia, trismus, soft tissue injury, hematoma, pain on injection, infection, and edema. These are all the local complications, which means that the complication will occur in that region where you are going to administrate the local anesthesia. We'll see in detail about a one by one in the upcoming slides. Moving on to the needle breakage. The name itself states that the needle will get break when and how. The cause is the bending of the needle, sudden unexpected movement of the patient, entire length of the needle is inserted into the soft tissue. Use of the smaller needle. For example, if you use a 40 gauge needle, the chances of getting breakage will be more. How to prevent it? Use a large gauge needles, especially with the inferior alveolar and the posterior superior alveolar nerve. Use a longer needles. Do not insert a needle into the tissue to its arm. So you should not insert the entire needle into the soft tissue. This line states that. Do not redirect a needle once it is inserted into the tissue. What does it indicate? It's nothing but when you insert a needle into the soft tissue, to that position, do not redirect the needle. When you want to redirect the needle, just remove the needle and again reinsert the needle instead of redirecting it into the same in the same position. So that will cause the breakage of the needle. How to manage it? When the needle gets break, and now you will manage it. When a needle breaks, stay calm, instruct the patient not to move and let his mouth open. If a fragment is visible, remove it with a hemostat or a Magil intubation forceps. This is an instrument which shows that it's a Magil intubation forceps, and this is the hemostatic instrument. So this helps us to remove the needle when it is visible. When not visible, how to remove it? No incision or a probing. Calm the patient. Refer the patient to the department, a required department. Take a radiograph and determine if it is superficial, remove or leave it and flow up. Because when you leave it, the tissue surrounding the needle will get inflamed, and as a result of it, the needle will get pushed out within a few days. So within a few days. So this is the management. When the needle gets breaks and when it is visible, you can remove it simply with an hemostat or Magil intubation forceps. If not, this you have to do. Coming to the ocular complications. The ocular complications are temporary blindness, mydriasis, which is nothing but a pupillary dilatation, and this picture shows that the pupillary dilatation, ptosis, droopy eyelids, and the diplopia double vision can occur. What is the cause behind it? It is nothing but inadvertent arterial injection with a retrograde blood flow. What is this? Inadvertent injection into the orbit through the infraorbital fissure. When you inject the local anesthesia into the infraorbital fissure, there are chances of getting an ocular complication will be more. How to prevent it? Aspirate before actual injection. Slowly inject the anesthesia. Treatment will be reassure the patient that is transient. Cover the affected eye with the gauze dressing. Refer the patient to the ophthalmologist for evaluation and it last more than 6 hours. If it is like if the symptoms last for more than 6 hours, it's usually a transient. Transient is nothing but a temporary, so it will subside on its own within a few hours. If not, if it is persists more than 6 hours, just simply refer the patient to the ophthalmologist and follow up the patient. Coming to the third complication, which includes paresthesia. What is this paresthesia? It is nothing but it's the prolonged anesthesia in the particular region. How it occurs? The causes will be trauma to the nerve, local anesthesia solution contaminated by the alcohol or sterilizing solution near a nerve produce irritation, resulting edema and increased pressure in the region of the nerve leading to the paresthesia. Insertion of the needle inside a foramen, hemorrhage, increased pressure will cause a paresthesia. How to prevent it? Proper care and handling to the injection, control and cartridge. What to do to manage it? So most paresthesia resolve within 8 weeks without a treatment. The sequence of management will be similar to all other procedures. First step is to reassure the patient, examine the patient and follow each 2 months. If sensory deficit is still more than 1 year, Consult with a neurologist and a respective department. It occurs when anesthesia is introduced into the deep lobe of the parotid gland. So this is the one of the complications, which is nothing but facial nerve paralysis. When does it occur? Usually it occurs when you inject the needle. For example, when you are going to give an inferior alveolar nerve block, IAND block. Since, as I told in the previous class, what are all the structures which is present around the inferior alveolar nerve? I told you that there is a posteriorly you have a lobe of the parotid gland. Whenever you insert or advance a needle in deeply into the soft tissue, you might reach the parotid gland, and when you insert the needle into the parotid gland, you will the chances will be more to damage the facial nerve because the facial nerve courses along the parotid gland. I hope everyone knows that the terminal branches of the facial nerve will course along the parotid gland. So whenever you touch the parotid gland, there are chances of anesthetizing the facial nerve, which resulted in the facial palsy. So this is a picture which shows a facial palsy. In case of a facial palsy, the palsy side. So this the left side is appears to be a palsy side because the muscles which is present in the normal side will tend to pull towards that region. So as a result of it, the palsy side will appear like this. So what is the cause behind it? As I told, transient facial nerve palsy caused by local anesthesia into the capsule of the parotid gland, which is located in the posterior border of the mandibular ramus. Usually it occurs during an IAND or a Vazirani-Akinosi technique. I hope you people remember that what is called as Vazirani-Akinosi technique. For your people, I just tell you a few sentences about the Vazirani-Akinosi. It's a closed mouth technique, most commonly used in the patient who is having a restricted mouth opening. How to manage it? Reassure the patient. Usually the patient have paralysis or transient one and it will resolve on its own, doesn't require any treatment, but duration of that, during that period, you have to support the people. So sometimes the patient will not be able to close his eyes properly because of the one of the symptoms of facial palsy. In such cases, an eye patch should be applied to the affected eye or manually close the lower eyelid periodically to keep the cornea lubricated. If the patient has an habit of wearing a contact lens, make sure the lens should be removed. Coming into the other complication, which includes trismus. What is a trismus? As I told, trismus is the restricted mouth opening. A pain and difficulty of opening often after the PSA nerve block or IAND. Why does it occur? This because, as I told in the previous class, PSA or IAND is close in relation to the masticatory muscle. When you insert the needle inside the pipe into the masticatory muscle, the fibers of the masticatory muscle will get damaged. As a result of it, the inflammation of the muscles will cause the shrinkage of the muscle and the restricted mouth opening. Onset will be 1 to 6 days post-treatment. What is the cause? As I told, trauma to the muscle and the blood vessels in the infratemporal fossa. Local anesthetic solution contaminated by the alcohol or cold sterilizing solutions produces irritations of the muscle. Low-grade infection. How to prevent it? Use a sharp, sterile, disposable needle, proper care and handling to injection, control and cartridge, a traumatic injection and avoid repeating of it. How to manage it? Heat therapy, warm saline rinse, analgesic like aspirin, muscle relaxation if necessary, diazepam 10 mg BD, physiotherapy for 5 minutes each 3 to 4 hours. If there is an infection, administer antibiotic. Improvement starts within 2 to 3 days and the recovery occurs within 4 to 20 weeks. Surgical intervention is required whenever the condition presses for more than 20 weeks. Coming into the soft tissue injury, this is most commonly occurs in a pediatric patient. This because whenever you give a IAND, the IAND along with the lingual and the buccal nerve block, this will cause a paresthesia of the lower lip. Since the pediatric patients are very small patients and unknowingly the patient will bite their lips. So as a result of it, it will cause a soft tissue injury. So trauma to the lip or a tongue caused by biting or chewing these tissues while still anesthetized, especially for the children. How to prevent it? A cotton roll, this is a pictorial representation, shows that the cotton roll is placed between the lips and the teeth. Warn the patient and self-adherent warning sticker. So this is the picture shows that the warning sticker has been stuck to the patient's forehead. So this indicates that the patient should not bite this lower lip. How to manage it? Analgesic for the pain, antibiotic if there is infection, warm saline rinse to aid in decrease the swelling, petroleum jelly to cover the lesion and to minimize the irritation. Coming into The another complication is hematoma. Diffusion of the blood into the extravascular spaces can result from inadvertently of blood vessels damage caused by leaking to the artery or a vein. Mostly occurs in IAMB and the PSA nerve block. 7 to 14 days, the hematoma will be presented. How to prevent it? Once you know the anatomy in a proper way, use a shorter needle for a PSA, minimize the number of needle penetration, never use a needle as a probe in the tissue. How to manage it? Direct pressure applied on the site of bleeding. Apply a cold moist towel to the affected area each 20 minutes in every hour. So this is most common complication in PSA. As I told you, when I taught the maxillary nerve block technique, where PSA, the pterygoid venous plexus is present in close proximity to the PSA. So whenever the pterygoid venous plexus get hurt, it causes an hematoma, which will be visualized manually within a few seconds of entering the needle into the pterygoid venous plexus. So immediate management will be application of the extraordinary pressure. Advise the patient about the soreness and the limitation of thin mouth opening possibility. Pain on an injection. So this is most commonly occurs in all the type of an injection. So that it doesn't mean that this complication is only suitable for local anesthesia. Whenever you give an intramuscular injection or IV injection, the pain will be there at the site of injection. So this is the most common complication of all the injections, and this is also a special of the local complication of local anesthesia. Careless injection and calculus attitude palatal injection always hurt. So among all the local anesthesia, palatal injection will always hurt. As I told you that the underlying submucosa will not be there. The skin is directly adherent to the bone in case of a palate. So whenever you inject the palate and if you are going to give palate a nerve block, the pain will be more. Dull of the needle because of the multiple injection. Rapid deposition will also cause the pain. How to prevent it? Adhering to the proper technique of injection, both anatomical and psychological. Sharp needle should be avoided. Topical anesthetic should be given. Inject slowly. Temperature of the solution should be maintained. Coming to the infection. What causes the infection? Contamination of the needle now become rarely after the introduction of sterile disposable needle and glass cartridge. How to manage it? Once infection has occurred, have to give the antibiotic. The most common antibiotics will be penicillin 250 mg QID. Other is the burning on injection. pH of the solution deposited in the soft tissue, plain LA has a pH of 6.5 by 3.5 when a vasoconstrictor are added. Rapid injection of LA in the dense area. Prevention is buffered solution should be used, and then slow deposition of the solution should be used. Coming into the other complication is edema. Causes is edema is similar to that of the hematoma. So, trauma, infection, allergy, angioedema, hemorrhage, injection of irrigating solutions with alcohol and cold solution. How to manage it? Minimum degree of edema depending upon the size of the edema. This is very minimum. Just give an analgesic for the patient to relieve the pain, and the the edema will resolve within a few days. If it is large degree of edema and signs and symptoms of infection has been there, given antibiotic should be given to the patient. So this is the most common complication as I discussed in slides. And I hope you people have understood the common complications and how to manage it. So with this knowledge, I hope you people will never cause the local complication whenever you are going to inject the anesthesia. Thank you.